if the children are above 20 kilos and who can be adjusted to the adult machine. So the study setting was a Black Lion Hospital, which is in the capital city of Addis Ababa. It's a teaching hospital of Addis Ababa University. And we have seen cases of children over a little over 2 years. And we did a chart review, a retrospective chart review of children who have received renal replacement therapy. And so those who we didn't keep record of properly and data were missing were excluded from the data. So we had a total of around 35 children whom we were able to retrieve the data. And of this, majority of children received acute peritoneal dialysis and the rest received hemodialysis. So from the children who have received dialysis, the main cause of indications for dialysis were pulmonary edema with oligoanuria and the underlying severe sepsis with secondary acute gastroenteritis and also glomerulonephritis. We don't do biopsies, renal biopsies, so we just clinically diagnose as having post-infectious glomerulonephritis or post-streptococcal glomerulonephritis and rapidly progressive glomerulonephritis and clinically manage. So the overall mortality was around a bit higher than we expected. We had several complications, and the children who come to us as a tertiary referral hospital, they present to our hospital late, and we actually we choose children to whom to give dialysis because we don't really have much catheters, and it's really difficult managing everyone. So we kind of, the term that I've used, everyone using is a very great term, rationing of treatments. So we do not provide renal replacement therapy for all children who require it and who come to our ICUs. So this was the case varieties that we've seen. So majority of cases fall into glomerulonephritis, though we don't really have a clear histologic diagnosis of it. And the others are a couple of HUS and hepatorenal syndrome and post-cardiac surgery failures are the few. And of the patients we've done peritoneal dialysis, we had 9 complications. 9 children had developed complications. So we use a rigid catheter, so it ends up having blockage and also leaks. And a couple of other children developed as well peritonitis. Okay, so what we've seen from all of this experience is basically if we were able to dialyze patients on time and also manage AKI accordingly and address complications on time, like life-threatening complications like hyperkalemia, fluid overload, or metabolic acidosis. Here I have to comment that we don't measure metabolic acidosis as well. We have clinical parameters to decide whether a patient is having metabolic acidosis, and electrolytes also may take 24 to 48 hours to get back. So we just assume that the patient has complicated with severe AKI. So we should be able to address such conditions, and we should be able to manage fluid resuscitation properly, and drug adjustments should be done clearly. And so the limitations that we have had were, though we are only 2 of the pediatric nephrologists available, and we don't provide that much of dialysis, we still had problem keeping data. And that I've seen, like it's quite useful to share our experience and also learn from our past experience. So we had limitations in keeping of data and utilizing it for features. And the fact that we're using rigid catheters makes it quite difficult for peritonitis and leaks. And also the fact that we don't have any available fluids, that we're using Ringer's lactate and producing it at bedside has an increased risk for infections. So in conclusion, we recommend that AKI should be managed medically and should be suspected in specific hospitalized hospital children, and we should be able to identify risk groups and manage them accordingly so that we can alleviate and prevent mortalities from simple treatable conditions like sepsis and dehydration. Okay, these are my references. Thank you.